Welcome to a new episode from podcast Doctors from Zahra Hospital in Dubai. Today, we are honored to have Dr. Mohan, our consultant plastic surgeon, today to speak more to us about plastic surgery and the specialties that plastic surgery is involved in as well. Welcome, Dr. Mohan. So happy to have you today.
Thank you very much, and wonderful to have this opportunity to connect with the audience and to introduce my specialty and also a little bit about myself.
Of course. Please
Right.
tell us more about Dr. Mohan.
So my full name is Mohan Rangaswamy, and usually I'm here known as Dr. Mohan. I've been in Dubai from 2002, and I joined Al Zahra right from its inception, even before the soft opening. I think that was back in 2013. And I come here twice a week and more if necessary.
Yeah.
And I've been providing comprehensive plastic surgery services to this hospital, which involves my own specialty kind of cases and also a lot of interaction with other specialists in helping to solve problems in each of their specialty.
Of course.
Sometimes plastic surgeons are able to help other specialists in solving some structural problems and healing problems and other types of problems in other areas where the patient may present to, let's say, an orthopedic or an ENT or ophthalmologist, and they find a problem for which plastic surgeons have the best solution.
Yeah. Actually, most people, when you tell them plastic surgery, the first thing that comes to mind is cosmetic surgery.
That's true.
So I would like to speak to us more about that. And what other than cosmetics does plastic surgery do?
I think we should start at the beginning, and we should convey why this specialty is called plastic surgery.
Exactly. Where does plastic, the word
and,
plastic
and who
comes
is a
from?
plastic surgeon?
Exactly.
So people often ask me, do you use plastic so it is plastic surgery? No, absolutely not. Plastic comes from the Greek word plastikos, which means to mold. That is why plastics are called plastics, because they are made by molding the base material into different shapes. Mm-hmm. That's how you get a plate or a cup or whatever.
Yeah.
So plastic surgery actually started in India, and in 600 BC, and I'm sure before that, but the records that have been discovered are dating to 600 BC.
Wow.
Can you imagine?
That's...
So at that time, they were making noses and various other parts, missing parts of the body, by transferring tissue. And even today, the Indian technique of transferring skin from the forehead down like this to rebuild a nose that is lost due to injury or trauma or war or whatever is called the Indian rhinoplasty, and that method is still followed. So there's an interesting story there that when the British were occupied in India and they were fighting different kings there, the British lost some of the wars.
Okay.
And the soldiers who were in British army, they were Indians actually, recruited. And one of the cartwheel driver, they had these carts, bullock carts, to bring their cannons. So this cart driver was caught as prisoner of war. In those days, the punishment for any crime is to cut off the nose.
Oh.
So this guy's name is Kovas G, and he returned back to the British barracks with a missing nose. And everybody, pitied him and so on and so forth.
Yeah.
1 year later, he had a nose. So the British officer who had seen him earlier, he said, how come you have a nose now? He said, I got it made like as if it's ordinary thing.
As if it's something that happens naturally and usually.
So he couldn't believe, but here is a nose, he has to believe. So he said, show me where. So a couple of doctors went, the army doctors, they went, and they witnessed the surgery and reported it in one of the magazines in the UK. That got picked up in Europe, in Germany. And so the European world came to know that plastic surgery kind
existed.
of thing, you can shift tissue from one part to the other part.
And that's a part of the molding, as you
it's
just
molding,
mentioned.
yes, it's molding. But really plastic surgery took off in the world wars, because in World War I and particularly World War II, there was this trench warfare. People would dig trenches, the soldier will be inside, only his face is exposed, and he comes out and shoots and hides again.
So they get a lot of injuries and
in the face,
accidents.
Yeah, parts of the face get blown off.
Yes.
And surgeons didn't know what to do with these people. They are healthy, they are alive, their body is intact, but part of the face is gone.
Yeah.
So some surgeons, army surgeons, were tasked with finding ways to treat these unfortunate people, and that's how gradually, as we say in plastic surgery, the problem suggests the solution. We have a very famous saying in plastic surgery.
Yeah.
The problem itself suggests the solution.
Exactly. It
So
depends
they
on
started quantifying the problem, 3D imagination, and trying to see how they can shift tissues from one part to the other. Long story short, from 1920s, 30s onwards, the modern plastic surgery is born, until significant changes in the 80s. Until then, it was mainly certain simple techniques, but a lot was done during that time. The principles were established.
During that time, was it mainly reconstructive, or
Absolutely.
there was something for beauty reasons
Absolutely.
or for aesthetic reasons?
Absolutely, it was reconstructive mainly. But cosmetic surgery had started slowly. It was done in secrecy.
Oh.
And the people who did it, they didn't want others to learn.
Okay.
They didn't allow anybody into their theater, and some celebrities would go there and get small things done.
Yes.
In fact, facelift by just lifting the skin was done by Madame Noel, 1901, I think.
Yeah, that's quite a long time ago.
Yeah.
But we can still see this pattern until today, that some celebrities, they try to hide that they've undergone
the patient may try to
surgery,
hide, but the doctor should not hide techniques.
Yes, of course.
Yeah. So anyway, that has got democratized now. So we have lots of trainings and conferences. There is a separate society for aesthetic cosmetic plastic surgery.
Yeah.
So who is a plastic surgeon is a question that sometimes even doctors don't know. So plastic surgeons are those people who first of all train in surgery, like myself. I trained in general surgery. I was a general surgeon first. Then we go for a specialized residency, which may last 3 years, do plastic surgery. And then you may follow it up with fellowships. For example, somebody does fellowship in cosmetic surgery.
Of course.
In microsurgery.
They can specialize in a subspecialty in plastic surgery.
So that's how the plastic surgeons are trained. So it's a long journey. First to become a doctor, then to become a surgeon, then to become a plastic surgeon. Yes. And
of course, plastic surgery has a huge role in reconstruction for many patients, especially patients who have been through either traumas or injuries
or
burns or wounds.
Yes.
So how can you explain the role of surgery in reconstructing these patients' looks and also their psychology?
Of course.
Because of their body image. So how does it play that role?
Yeah, good question. And like I said just before, that plastic surgery was born in war.
Yeah.
Right? So plastic surgeons think differently. What is our training? Our training is unlike other specialties. In other specialties, you learn about diseases of that specialty.
Yeah.
Learn the classification, the treatment protocols, etc., etc. You get skilled in how to do certain procedures if it is a procedural specialty. For us, it is principles. We are drilled and grilled in principles and trying to dissect a problem. We have what is called treatment planning sessions.
Okay.
We don't have so many presentations and other things in our training, but we have very strict treatment planning sessions where there will be one patient with a certain defect or a certain problem. All the plastic surgery residents have to examine him or her, come up with a plan. And the consultants also have to come up with a plan. Then everybody goes on the stage and presents his plan, and the plan is criticized.
Yes.
So what we realize is for one problem, there may be 5 solutions.
Exactly. I was just going to ask, I'm sure there is room for different options.
Opinions and options.
To solve the problem.
So basically what you have to see is first be able to define what is the problem in its essential steps in a 3-dimensional way. What is missing? What type of tissue is missing? What is the size of the missing area in reconstructive, right? What are the options? And you look, where is the tissue excess? Here there is a tissue deficiency. Where else on the body there is a tissue excess which I can transfer?
Exactly.
All right. So this is how we make a treatment plan. So coming back to what we do in reconstructive, let's start with birth defects.
Yeah.
So there are babies born, let's say, with a cleft lip or a cleft palate. Yes. Maybe the ear is deformed. Maybe they have a big, huge birthmark. Maybe the genital area is not completely normal.
Yeah.
Fingers are conjoined.
Skin also.
Skin marks, skin blemishes. Yeah.
Yes.
So these things, when they are there, structural, visual, and sometimes also functional. Like when the fingers are conjoined, it's functional. Cleft lip and palate is functional. So these problems we can fix.
Okay.
So birth defects directly into plastic surgery. Those which are external birth defects.
Yes. And at what age
each
for a baby you can start?
Each problem has a particular age,
favorable
age, or age by which it should be done, or the optimum age, let me put it that way.
Yes.
Like cleft lips, we prefer to do around 3rd month. Yeah. Cleft palate, we prefer to do around 1 year of age.
Okay.
And so on.
Okay. Because it depends on the level of also the safety for the child.
The safety, the development of that part.
Yeah, exactly.
And when that part's functionality is important, if the functionality, let's say speech doesn't develop, you don't have to repair a cleft palate at 1 month of age.
Yeah, you don't have to put them under the risk if it's unnecessary. Exactly.
Yeah, exactly. So birth defect is one, and staying with alphabet B, burns. Because plastic surgeons are specially trained in burn management. Of course, burn can be managed by general surgeons, GP doctors, minor burns, but we are skilled in managing all types of burns. So burns is another area.
And do you consider plastic surgery on burns, is it a necessity, or it's more of reconstructing the area to look better?
Okay,
or
there are two things
are
here.
there times where plastic surgery is essential for the wound or the burn?
Absolutely. Wonderful question. You are very perceptive. So you see, every burn cannot be treated by a plastic surgeon simply because there are not so many plastic surgeons and they are not sitting in the emergency room.
Exactly,
Yeah.
yes.
So the emergency doctors can deal with the first aid and all those things.
Yeah.
Then there are criteria when to admit and when the patient can be managed as outpatient. If it is matching those criteria, the patient can be discharged after treatment and bandages are given, ointments are used, and then they can be referred to the plastic surgery clinic to be seen few days later.
Okay.
Then there are major burns. They need to be admitted. They need to be under the care of a burn unit,
Of course.
which may have plastic surgeons, non-plastic surgeons, specialty nurses, and it's an organized burn unit approach.
Yeah.
Al-Zahra does not have a burn unit. So we sometimes admit, medium burns, but because the way we are structured, we don't have a burn unit. Now, let's say the burn is healed, and then there are contractures.
Yep.
Or even before the contractures develop, plastic surgeon can be consulted because we have a variety of treatments to prevent, bad results and to favor a good result of this healing. But let me tell you that if a burn area, in a smaller area, let us say, the patient did not go to burn unit, was managed by dressings, in 2 weeks' time, if there is not good healing, must see a plastic surgeon.
Okay.
You can see earlier, and absolutely any burn that has not healed in 3 weeks may require a skin grafting.
Okay.
It's useless to delay this, drag on, and then develop a bad result. Much better to skin graft.
There be a risk of infection or
Exactly. All those things, infection, contracture, functional problems, bad cosmetic result, and so on.
Yeah.
So burns is absolutely an area where plastic surgeons ideally could get involved. Sometimes it's not clear deep burn or superficial burn. The patient comes to the clinic. I say, okay, this is superficial burn. It can be managed simply by dressing.
Yeah.
And after that, I don't have to see immediately. Will be handed over to the wound care nurse who can supervise the dressings, who can perform the dressings.
Yeah.
And I will see probably after 1 month to talk about future prospects.
So probably future prospects would be one of them is scars, right? Because a lot
How
of
to minimize
wounds,
the scar.
burns can leave scars that can stay lifelong. So what's the difference between dealing with a new scar or a many, many years old scar?
Okay. Before we get into this question, there is just one more thing I want to say about burns. This is a message to all the audience. It's a social message. The sentence that I want people to know and memorize in their head: pour water on that burn.
Okay.
Pour water on that burn. So why do I say this?
Yes, elaborate.
If there is a burn due to flame or due to hot liquids, immediately don't lose seconds. Don't go to the phone. Don't try to call somebody. Don't try to reach a hospital. Pour water.
That's a great advice, yeah. Because
Take the person under the shower. Let the water cool the person for next 5 minutes. Just run the water on the burn.
Cold water or just room temperature?
See, why I'm not saying cold water.
Yeah.
People will then waste time looking for cold water. Waste time looking for ice.
Yeah.
Water. If this accident happens in the kitchen, run to the sink, open the tap, put your hand under the tap.
Okay.
Because seconds matter. It's very simple logic. The hot object or the liquid has just touched the outer layer of the skin.
Yeah.
In the next seconds, the heat is
We'll
penetrating to the deeper layers, right? So we want to stop that. So once you have done with the water, now you bought a little time.
Yes.
Now you look for cold or a pack of frozen peas, whatever, put it in a bag and put it on that area. It will do two things. It will cool the area. It will give pain relief.
Okay.
The best way to give pain relief to a person who is crying in pain due to the burn is to cool the area.
Cool the area, definitely.
Cooling gels, yeah? So this is a social message. Now what you should not do.
Yeah, that's a very good point. What you should not do.
Please listen, do not apply toothpaste.
Okay, that's a very good one because I know a lot of people who do. Yes.
And why do people do this?
It's a misconception.
Why do
cultural
people do this?
thing. I don't know.
Because toothpaste contains menthol.
Oh, it cools.
Menthol gives a cooling feeling.
Oh, yeah.
Because it fools the nerves. So the nerves are, menthol does this to the nerves that you feel that there is cooling.
But it's a temporary thing.
There is no physical cooling.
Oh, okay.
Number two, toothpaste contains a lot of chemicals which are meant to get that dirt off your teeth. So it contains harsh chemicals, and that's not what you want to apply on a burn
so
which
it
is
might
already.
make it worse.
Yes.
Okay.
Yes. So some people ask me, cold milk. Yeah, okay, cold milk is fine, but will you waste time looking for cold milk?
Yeah, cold water. Generally, water is more available. So just grabbing.
So that's an important message I want to say, because then if you cool it immediately, the burn will remain as a second degree superficial.
Okay.
If you did not do that,
It will
you lost time. It can become a deep or a third degree.
Oh, okay. So yeah. So we tell everyone, please pour water on your burns before they advance.
Yeah. So the other thing now, your question.
Yeah, the scars.
Coming to your question, scars. So young scars, all scars improve with time.
Yes.
Okay? Yeah. So young scars need compression. Very important. Often this is not discussed.
What
Compression of a scar is the best treatment. So for example, if there is a post-burn scar here, then they have to go to a specialty shop. There is one in Dubai. There are a couple of guys who make it.
Okay.
And then they measure it and make a compression garment. It's like a sleeve, tight sleeve.
Okay.
And they have to wear it for 3 months minimum. It
After
will after the healing.
Okay.
After the healing. So it compresses that area.
Yeah.
Vertical compression of the scar.
Yes.
Reduces the blood flow.
And it makes it more even, right?
More
The
even,
skin.
makes it softer, and prevents thick scars from forming.
Oh.
And in more serious burns, wear the garment for 6 months. Change the garment once it has become loose. Obviously, the garment is going to become loose in a couple of months.
Working.
So you will need a new garment.
Yes.
So silicone, either cream or sheets, on top will be compression.
Okay.
This is the most important
Most
thing.
effective.
And for 6 months, we generally don't like to operate, do scar releases or grafting, because it has to mature. The scar has to mature.
Yeah.
Operating in an early stage in an immature scar might give you bad results. So listen to the surgeon. The surgeon will choose the most appropriate time for the scar.
For the scar. What about old
Again,
scars?
that brings a principle in plastic surgery. Anything that can be honorably postponed should be postponed.
Of course.
This is one of our principles. Will you believe it or not? We sometimes want to delay.
Yeah.
Delay for the sake of the patient, because the tissue will be in a better condition 6 months later.
It could be, that's what we always say, like listen to your surgeon because they know what's better for you. It might be for better healing, for better results.
Yes.
So the timing makes a difference.
Absolutely.
So I think before jumping into decisions, we need to take the time. But what about old scars? Someone might have had a wound while they were kids and they grew up to still have...
Correct. If the scar is not functionally contracting, preventing bodily functions, then it is for the appearance.
Yes.
But either which way, old scars can be improved. I mean, that's not a blanket statement. We have to see each case.
Yeah.
But in the vast majority of cases, improvement can be there. For example, the childhood injury that you talk about, maybe it was not stitched properly. Maybe the deep layers were not stitched. Or maybe it was just dressing was done and it was allowed to heal.
Yeah.
So now we can take out the scar, do accurate closure in a plastic surgical way, and then you can get a better result. And then, of course, silicone, compression, all these things will follow.
Will follow,
and you can really sometimes achieve remarkable results. But every case is unique, every case is different, and we have to examine, make a careful plan, maybe more than one plan, discuss the plans as I told you, and then work with the patient on this one.
When does a plastic surgeon say no?
Many times.
Give me an example of a time where you have to say no.
Let's say a person is obsessed with the scar. Yeah. And I see that the scar is quite fine, appropriate for the trauma and for that part of the body. And there is what is called subjective and there is what is called objective. I'm looking at the patient, I'm giving an objective assessment.
Yes.
The patient is looking at it subjectively, has an emotional baggage.
Definitely.
Maybe this was associated with some adverse events.
It reminds him of something, it gives him a bad feeling, bad image.
Exactly. And I see that doing a scar revision is not going to remarkably improve this. So I say, why should this guy, spend that money? And plus, he's expecting something else, that it will disappear.
Okay.
It won't disappear. So if the room for improvement is not much, then I'm not going to offer that. Secondly, there are people, like, to take the same example, having unrealistic expectation. Okay. The expectation does not match what I can realistically provide with my skills and with my specialty.
Yes.
So then when there is no match, better to avoid surgery. Mm-hmm. Then there are people who already have let's say, more this happens in cosmetic surgery, for example, that they have a reasonably good body, or that particular thing that they are bothered about is objectively nothing much. So the emotional baggage and the objective analysis
Two
don't
different
match
things.
up.
Yes.
Don't match up.
Yes.
There's too much of trouble for something very small. So
you
we talk
face-
about risk-benefit ratio.
Of course.
Yeah. So in
Yeah.
that way, I turn down the patient. So there are many case situations when not psychologically ready.
Yeah. And do you go through someone bringing you a photo or wanting to look like
Yeah.
a certain figure?
This happens.
Or a
This happens
celebrity.
quite often. So we first of all tell them that is a different person
It's a part of unrealistic.
with different genes, different mama, different papa. That conveys the message.
Yes.
But then you're showing me this photo. I'll take a serious look at it, and I'll ask you what aspect of this that you like, to try to get to know their mind. See,
Yeah.
one of the most difficult things, and this again comes to cosmetic surgery, not so much in reconstructive,
Yeah.
is to know their mind. What exactly are they expecting? And much time is spent knowing the other person's mind, where looking at this photo in an objective way and asking the person, okay, what exactly about this? Then they may say, for example, women bring photos of the breast a little bit showing. They say, I want this and I want this kind of cleavage.
Yeah.
So I understand that she wants more of cleavage
Exactly.
and more of this.
So you understand the purpose. Or
purpose
the,
of showing me this photo.
Okay.
But other than that, if as it happens, I mean, without offending anybody, people come for like buttock enhancement. Let's say she is of a certain race or a certain nationality.
Yeah.
And she'll say, doctor, I'm going to show you some photo. Even before she shows, I know that she's going to show me a black woman's photo. Because black people tend to have a certain figure, which is very well endowed in the buttock area. And she'll show me that photo. I say, look, that's genetically different.
Yeah.
Each race has a different body structure.
Not everyone can look
No, different body
the
structure.
same, yeah, because they're
So
built
people
differently.
from the Far East have a
Yeah.
different nose.
Definitely.
So when that person comes and wants a certain thing done, I want to correct the nose so that it still aligns with the ethnicity.
Yes.
African
Needs to
person
look-
comes, it has to look
Yeah.
aligned with that ethnicity. Just correct those things which are grossly deviant.
So enhancement without
Changing the identity.
Exactly. So it's enhancement and beautifying.
Yeah.
One last thing I want to ask about is the breast cancer reconstructive
Right.
surgeries after surgeries related to breast cancer. How does this medically and psychologically play a huge impact?
Absolutely,
with
absolutely.
patients?
See, let me introduce another concept here, that advances in plastic surgery have helped advances in other specialties.
Yeah.
Two areas I would like to mention. One is breast cancer treatment, and one is orthopedic management of fractures, especially bad fractures, where the soft tissue is also gone, the skin coverage is gone. Plastic surgeons have made tremendous progress. And nowadays, major limb injuries are to be managed combined, orthoplastic.
Yeah, true.
And that is much better for the patients, faster recovery, avoiding trouble, avoiding complications, having a more smooth recovery. Okay. But coming back to your question of breast cancer, see, earlier the breast cancer treatment involved mastectomy, removing the breast, and radiotherapy
Yes.
and chemotherapy.
Yeah.
Now that reconstructive surgery is so advanced, we are more and more thinking of doing the mastectomy but not leaving the woman with an absent breast,
Yeah.
with a flat
exactly.
chest.
Exactly. Because that
Earlier
affects-
it used to be said that you must finish the mastectomy so that she lives with a flat chest for some time, so that when you make your new breast, she will appreciate that breast that you have made. Why this approach?
Yeah.
Why this approach? Because the reconstructed breasts were not so good.
Good. Yeah. Okay.
The level of reconstruction had not reached that degree of perfection. So this was some kind of a philosophy. Also, earlier we used to see more advanced cancers. So there, doing mastectomy and reconstruction together may not be the best thing, because the cancer treatment may be interfered with. So they said, okay, finish with that, then come back.
Okay.
Today, we are catching the cancers earlier.
Treating earlier as well.
So catching them earlier,
Yeah,
therefore treating them earlier.
Definitely.
And in a situation such as this, the skin is not involved, the nipple is not involved. So what we do today is a skin and nipple sparing mastectomy. So only the breast tissue with the cancer is removed.
Okay.
So now we have the entire skin envelope, we have the nipple intact, and so we can reconstruct this. So this involves usually a two-step approach. The first step, we place what is called an expander.
Okay.
so that skin doesn't shrink. We fill it with fill it with saline
shape.
water to keeps the shape. So psychologically, she already wakes up from mastectomy with a breast, and within a few weeks, I will inject more saline into it. So it will be a complete fullness.
Okay.
So she will be like in dress or without dress, she will look normal.
Okay, that's good.
And if there is radiation, there is a different protocol. If there is no radiation, there's a different protocol.
Yeah.
But basically, bottom line, in step 2, we remove that expander balloon and we put the final implant. And today we are also using what are called ADMs, or they are called mesh, acellular dermal matrix. This mesh forms another layer on the implant and improves the softness and the result. And then I'm adding fat grafting in the second stage.
Okay.
So there will be more fatty layer as in a normal breast.
Exactly.
So we will have skin, we will have a fatty layer, then we will have the ADM, then we will have the implant.
So it will look and feel as natural as possible.
And the amazing thing is, after fat grafting, patients tell me, doctor, I have regained the sensation on the skin. Because after mastectomy, sensation on the skin goes.
They lose the sensation, and that's common, yes.
And patients volunteered this information. That's when plastic surgeons came to know that fat grafting can actually help somehow for the sensation to come back. The hypothesis is that the fat acts as a conduit for the nerves which are cut to start growing again and coming that way.
That's very interesting.
And then fat grafting can reverse some of the bad effects of radiation. This is again not widely known.
Okay.
So in Zahra now, we have a comprehensive service. We have breast surgeons who are doing the mastectomy, and I'm often with them during the mastectomy, and I help them with the mastectomy. And then I perform the step 1 of the breast reconstruction. Step 2, then it's completely by me. And we are incorporating fat grafting. So every modern technology has been included. And for those who have a better budget, we can add stem cells. So everything that you add, the ADM, the fat grafting, the stem cells, enhances the result 1 step, 2 step, 3 steps further.
Exactly. To give them the best possible.
Right. Some of these things are not covered on insurance. Some are covered. So in these kind of things, when we are incorporating all the modern advances, maybe it depends on the budget of the patient. They may have to.
That's what, at the end of the day, that's what decides
whether we can add these advancements.
That's the patient
because these things cost. They are expensive.
Exactly. Now we hope everyone gets the surgery they need to make them feel better about themselves or to heal their wounds. If you have a final word to give us today, what would it be? Okay.
So plastic surgeons are surgeons with very specialized skills and a different way of thinking. It's almost as if our brains are wired differently, because when we look at a problem, immediately we begin analyzing it. Immediately we have a certain way to approach that problem, which by way of our training and experience is different from the other specialist. So it's sometimes if a wound is not healing well in a short period of time, if there is a structural defect, if there is an old scar-related problem, or birth defects, we have discussed all of these today.
Yes.
Please think of consulting a plastic surgeon. At worst, I will say, okay, this is not related to my specialty and I cannot fix it.
So
at worst.
Consult the plastic surgeon and he will guide you.
At best, you will be surprised at what we can do and what things are possible. Right?
Yes.
So that's the message I want to put out, that plastic surgery is a very, very vast and wide specialty. We are not limited by body area. We are not limited by disease process, because some specialties are related to a particular organ. Ophthalmology is to do with the eye. ENT is ear, nose and throat.
But you are
we are working from head to toe, any part of the body, in any age, and for a wide variety of problems with any tissues. So if you have issues with your tissues,
consult the plastic surgeon, right? Thank you so much, Dr. Mohan,
very welcome.
for the valuable information and the great time. And
and thank you for your wonderful and thought-provoking questions.
Thank you.
It was a pleasure.
Thank you.
Thank you very much.